Well, thank you very much, everybody, for having me back this morning, and thank you, Dr. Kavanaugh. That was excellent. I truly enjoyed that, a topic certainly dear to my heart. I wanted to share with you this morning some of the things we're working on within our lab in collaboration with physiotherapy and running coaches. And it's kind of an emerging area around modifying movement. In the physio world, for instance, with ACL injury prevention, physios are constantly working on retraining movement patterns. They'll see a certain movement pattern that may be a predisposing movement pattern to ACL injury, and they'll try to intervene. And so the idea here that people are working on now, and most of this comes from actually the physiotherapy community, is can we modify walking and running patterns to prevent injury and possibly manage injury? And I have a doctoral student who's working with me right now who's looking at this very question. And what I wanted to share with you today is how we measure different stride characteristics in the laboratory. And one of our mandates is actually to take that information and figure out clinical tools that you can use easily in your clinic. And there's a lot of things right now that you can have a look at simply with an iPad and a treadmill, and being able to take video from different views and slowing it down and looking at certain visual cues in someone's running style that you may be able to intervene with. So I'm going to share some of that with you today. It's not working. So for those of you who weren't here yesterday, I described a little bit about Fortius Lab, which is an integrated laboratory with physiology and applied biomechanics in Vancouver. I didn't mention yesterday that this is actually a philanthropic project, and the idea was to integrate physiology and biomechanics with sports medicine, podiatry, physiotherapy, and sort of bridge that gap so that we're working together. And for me, in the last year and a half, it's been tremendous, the conversations, the questions that arise from the clinical practitioners and how they really drive ideas about research and where we can go with this. And one of the things that we've been trying to do is look at how we can take quantitative measurement within the laboratory and apply it day to day for everyone who comes in. And I'm going to show you some of the work that they're focusing on right now. And the doctoral student who's with us is a physiotherapist who's also a running coach and is very interested in looking at stride frequency and different visual cues that you can use in your clinic every day to assess these things and perhaps suggest interventions. So overall, I'm going to talk a little bit about modifying movement strategies. Gait retraining, gait modification are some of the terms that you hear out there. And the emerging ideas around this focus on three different areas. And a lot of this comes from the physiotherapy community, Irene Davis and some of her students. Looking at some of these terms that are being used: medial collapse dynamics, crossing over dynamics, and looking at overstriding dynamics. So I'm going to describe each of those scenarios to you and then move on to, is there an application here for the avid walker? So we see a lot of people who are competitive elite runners. We see a lot of people that are recreational runners. But we also see a great population of individuals who quite clearly just want to be able to go for a walk to remain active. And so finding new tools for them, whether they're overweight, whether they have osteoarthritis or diabetes, is to me, a really intriguing area. So this is kind of what I'll walk through with you this morning. Now, I'll start with medial collapse dynamics, which many of you have probably seen day to day in your clinic. And the idea around this movement pattern or mechanism of injury is that it's a coupling or a coordination of increased hip adduction with hip internal rotation. And you see this what's called the contralateral pelvic drop. And this may or may not lead to increased knee abduction, or dynamic valgus is the term that's typically used in the PT literature. So it's sort of this combination of things that occur typically at mid stances when you can view it the best. And I mentioned yesterday about Silicon Coach and how we use that for an educational tool for our clients. And we'll take most of them through each part of the stance phase and show them the different variables that we're looking at. And here you can just see an example, and this was a young runner who came in to see us early last year. We've sort of stopped her at mid-stance, and we're looking at how much the contralateral pelvis is dropping. We're looking at the position of the femur or the thigh and the frontal and transverse planes. And then we're trying to think about how we can intervene to help this person perform. So somebody asked a very good question after Dr. Kavanaugh's talk about strengthening alone. And one of the reasons this area is emerging is because what we're finding is that different footwear interventions, different exercise interventions, strengthening for instance, and traditionally what you do here is increase the strength of the abductors, external rotators about the hip. Those interventions alone don't seem to be nailing it. We still have people that just aren't getting better, and the idea is that we also need to modify their movement patterns or their functional movement patterns. So this is sort of a description of medial collapse dynamics, and that term was really coined by Willie and Davis and Neuren. So the injury patterns that you typically hear that are associated with this movement pattern are patellofemoral pain syndrome, the number one overuse running injury, iliotibial band syndrome, and there's been a lot of focus on these two in particular over the last 10 to 15 years because of their high frequency, their greater frequency often in the female runner as well. So some of the literature indicates that perhaps it's a 2 to 3 times greater frequency in the female runner. There's some thought around labral tears, and right now, if you think about injury patterns, there's a lot of focus around groin injuries right now and labral tears, both in cutting sports and in running. Tibial stress reaction and fracture, and also maybe even plantar fasciitis. So these are injury patterns that are often associated with the medial collapse dynamics. So what are the interventions, and what can you do in this case if you observe this? And as I mentioned, this is something that you can capture if you have a treadmill in your clinic, and you can simply use your iPhone or an iPad to capture some video while they're moving. And so the idea would be for you to get them into mid-stance, and roughly that occurs when the knees are side by side, and you want to look at the weight-bearing limb versus the swing limb and what's happening with the pelvis and the position of the thigh relative to that pelvis. So for interventions, there have been some things that you can do in the lab, some fancy things where you provide real-time feedback to the runner, and there's some evidence to suggest that this is effective over an 8 to 10 session training where you're providing feedback. You may be looking at a plot of the hip angle in real time and coaching the runner as they're running. But in the clinic, that's not always possible, and so there's different things you can do with mirrors. And this is actually a method that Irene Davis introduced to me, where you simply recommend to your runner to run with the treadmill facing a mirror. And the cues that they're looking for as they're running are really to keep the knees apart and to keep your patellas moving, looking forward. So as they run, they're watching themselves, and they can make these adjustments. The other verbal cue often is to squeeze the gluteals together. And I'm still waiting for someone to explain to me how you do that, but keep that in mind. But the easier ones that aren't quite as intriguing are about keeping your knees apart, looking for more hip abduction and external rotation of the femur by trying to keep the patellas looking straight ahead. And they've shown, particularly Neuren and Wiley and Davis, that over sessions of about 8 to 10 sessions over 3 weeks or so, that the individual actually start to assume this movement pattern, a healthier pattern of movement while they're running. So this is kind of interesting because we don't typically think much about changing people's gait patterns, but it exists in a lot of different areas of rehab. We show people how to lift in a healthier manner. We show people how to position themselves when taking a jump shot or preparing themselves to do a cutting maneuver well, this may be an application where we can intervene with running and perhaps even walking style. So medial collapse dynamics. Now the second area is about crossover, and what crossover dynamics I think are really about are stride width. And so we look at footfall position when someone's running. Your base of gait, or your position when you're walking, is typically like this. As you run, your feet fall more along the line of progression. And with crossover dynamics, people actually cross over the line of progression. So there's a lot of hip adduction, and we see it quite a bit in different runners that have different problems with the lateral knee in particular. So visually, again, in your clinic, you could have a posterior or anterior view of your client running or walking, and view their stride width. And the general idea is just to drop the midline down to the foot and look at the position of that foot at approximately mid-stance. The definition clinically that most people are using is that if more than 25% of the heel is medial to that bisection line, then you may be dealing with somebody who is crossing over. So a decrease in step width, and in the lab we can track this quite accurately, but visually in your clinic you don't have the cameras. You want to do something that you can look at somebody, get them moving, and have a look at them in mid-stance. So you see this increased hip adduction at mid-stance. The foot position is medial to the center of mass. And with these individuals, I often see that just prior to initial contact, their foot is in a very inverted position relative to the ground, or increased running limb varus is a term that's been used. And so you typically see this very elevated rear foot eversion velocity. There's a lot of eversion or pronation excursion that has to occur in order to get that foot down on the ground. Injury patterns. Often we will see iliotibial band syndrome, again, different types of stress fractures. I've had about 3 or 4 athletes that have had third and fourth metatarsal stress fractures that have exhibited a crossover pattern or decreased stride width. And also Achilles tendinopathies of tib posterior as well. There's because that foot is so inverted prior to foot contact, and there's great eversion velocity and excursion, we tend to see tendinopathies of tib posterior as well. So again, a simple solution is to have your athlete train on a treadmill in front of a mirror, and to keep the knees apart is the verbal cue. Or you can position a piece of tape down the midline of the treadmill belt and ask them to straddle the line. Keep your feet apart. In the field or on the track, that have, if you have lanes of a track, you can ask them to straddle the line while they're running down the track. And again, Willie Davis and Willie on his own has shown over time, and if you practice this 3 sessions a week, usually for 2 or 3 weeks, that it'll stick. And the big question is how long will they maintain this healthier movement pattern? How do they continue to adopt that pattern, and does it need to be revisited? But there's been some great clinical outcomes, looking at just modifying these 2 particular movement patterns. And so in the lab, we can track the position of the ankle joint center, left and right, over a number of different footfalls. So here's our gentleman that I showed you just a moment ago, who was exhibiting a crossover footfall pattern or a decreased stride width. And down below, we've just tracked the ankle joint center over a number of different footfalls. Here's an individual who is exhibiting a greater stride width. In this case, it was about 12 centimeters. And you can see now how these trajectories are pulled apart. Okay? So that's one way we can do it, but you can do it simply with some video and some, if you're fortunate, have some similar online tools to be able to bisect and draw different angles. This is a great educational tool for your clients or patients. So there's 2 areas that are getting some attention, and there's been quite a bit of work done looking at how you can intervene with mirror running, for instance, or real-time feedback. The area that perhaps we've spent more time looking at, and I'm working with our graduate student on, is overstriding dynamics, which is really about decreased stride frequency, increased step length. Okay? And we evaluate this in all of the runners that come in to see us. And if you work with our competitive athletes, so Triathlon Canada, our top marathoners, our top middle distance runners, and you work with the coaches and the physiotherapists together collaboratively, you learn that what they train typically is to have a cadence or a stride frequency of about 180 steps per minute. And that just means that in any given minute, at their competition speed, the right side hits the ground 90 times and the left side hits the ground 90 times. So that's kind of a goal that's out there, and I've seen runners that are up as high as 195, 200, but they kind of coach that. That's what they aim for in their training. Now we see a great number of recreational runners, and the idea about overstriding is that they have a greater step length, decreased stride frequency. And those two are associated. In the recreational runner, who is either interested in injury prevention or management, and particularly those injuries about the knee, we assess this and we often see individuals more at 150, 155 steps per minute. So they're doing about 75 steps left and right. And so one of the interventions that has been studied more recently is looking at what happens when you increase stride frequency. And it's related to decreasing step length. And how does that affect the forces that are impacted on the body or absorbed by the body? And so we have two examples here of individuals that we've seen in the last year. And generally what we do is we have a look at their footfall position relative to the center of mass. So we drop a vertical line or plumb line down from approximately where their center of mass is, and we look at how that foot position is relative to that vertical line or the center of mass position. And for individuals often who have running injuries, we try to adjust that stride frequency to get the foot more under the center of mass or decrease that horizontal distance. And there's some great studies done by Brian Heiderscheit and others who have looked at the effect on each joint, and particularly the hip and the knee, and a decrease in the joint moments that occurs with increased stride frequency. And I'm going to show you a video in a moment, but what you'll notice is the key is that the center of mass, its vertical excursion decreases with increased stride frequency. So I talked yesterday about looking at the lower extremity as if it's sandwiched in between the center of mass and the ground. And that by decreasing that excursion of the center of mass, you can decrease the resultant joint moments at the hip and at the knee, and often those moments that have been associated with running injury mechanism. So typically, this is really about decreased stride frequency when you see this overstriding dynamics. And naturally, as your stride frequency decreases, step length increases. And so often, these individuals, just prior to contacting the ground, are not necessarily in a good position to efficiently and effectively attenuate force. And we look at this in each individual, and those primary mechanisms that attenuate force at that point of initial contact. Rear foot eversion, coupled with flexion of the knee and flexion of the hip. And so, what you see typically is the foot is out in front. They're not leading with the knee, they're leading with the foot. Clinically, you can see this. And generally, the hip is in more extension. The knee flexion angle is less at initial contact, and you see increased forces associated with that. The injury patterns, again, oftentimes it's patellofemoral pain, different stress reactions or fractures of the tibia, and again the metatarsals have been our experience, and very similar to the medial collapse mechanics or dynamics that I showed you before. And these things aren't independent of one another. You can see individuals who exhibit the medial collapse dynamics who are also overstriding. Now, interventions, and I showed you that gentleman yesterday with the case studies where he was running at about 155 steps per minute, and we increased his stride frequency. Now, we can do it in the lab. We have a large visual metronome that does left, right, left, right, left, right, and we'll match it to their performance, and then on the fly we'll adjust it and remeasure. It's very simple, though, to educate your patients to use an iTunes metronome. So there's a number of different downloadable apps now on iTunes that you can simply put on your phone. And with most clients, what I do is give them a goal. So in Heiderscheid's work, they show that there are decreases in the joint moments about the knee and hip with about a 10% or 15% increase of stride frequency. You can't necessarily recommend to your client or patient, I want you to try to decrease your step length, because they won't be able to do that. But you can naturally do it by increasing stride frequency. And so I'll send people off and show them how to use the metronome, and they'll train themselves on their runs. And once they become accustomed to using the metronome, they actually often will download songs that are to that beat. So this is empowering your client or your patient to take some responsibility and work on some things themselves. So this is just an example of a client that we had who was having unilateral telefemoral pain. The treadmill speed here, it's nice because you can keep this constant. So the one on the left is where she's running at about 150 steps per minute, or 75 left and right. And this is where we took her and asked her to increase her stride frequency to, I believe it was 170, and then we looked again at 180. And I've had a number of people that we've had them run at their preferred running speed, their preferred stride frequency, and we've had them run a bit of a duration, and they begin to experience knee pain, so whatever their primary complaint was. And I've also had individuals who, by increasing their stride frequency on the fly, that pain has resolved. So it's a very new area. We've got a lot of work to do to study it, but there does seem to be some improvement in symptoms on the fly in the clinic or in the lab. Also, what's been interesting is as I mentioned yesterday, we track the pelvic motion, and I mentioned to you about how important that is for affecting the hip angles and ultimately the knee. And I've seen individuals who at preferred speed, at preferred stride frequency, have exhibited asymmetries in their pelvic motion. I showed a bit of that yesterday. I've also seen those resolve with increased stride frequency, which is quite interesting. None of this, of course, is published, but we're observing as we go. And it'll be interesting to look into that a little bit about how this influences the pelvis, because it has such a huge effect on what the hip's doing and ultimately the knee. So if you watch those two together, you can get the gist. And I always describe to people, because they don't understand, that right now, this is what you're doing, and we need you to try to increase your stride frequency, decrease your step length. So here is the same client at initial contact. Around foot strike pattern, I have seen runners who we've increased their stride frequency and they maintain a rear foot strike pattern. I don't see a change in the footfall pattern generally with increased stride frequency. We've had some individuals that have progressed perhaps towards more of a mid-foot strike pattern, but most individuals, this is a very subtle adjustment that doesn't really affect footfall pattern that much. But what you do see is a change at the joint kinetics, and I'm going to show you an example of that in just a moment. So here is the same client, and here's the vertical ground reaction forces, left and right. What did Trevor say yesterday? His left is blue and his right is red. Is that right? We have left is black and right is red, so that I can remember. You'll see here generally that what's happened with increased stride frequency, so the solid line is her preferred stride frequency of about 150 steps per minute. And then we increased it to 170 and 180. And you can just see generally the ground reaction forces have decreased. The impulse or the overall amount of force has decreased. And what happens, we think, and not in all individuals, but generally speaking, is a decrease in a knee adduction or knee varum. Dynamic varum may be the term that you use. And ultimately, what's probably most important is a decrease in the internal knee abduction moment. So if you have a look at her preferred stride frequency of 150, you'll see the solid line. This is the knee adduction, so the knee goes into more varum for most individuals who are running. You can see that that's been decreased just slightly with increasing stride frequency. However, the forces, or the knee abduction moment, which has been shown to be associated with patellofemoral pain and iliotibial band syndrome in particular, has been reduced. And I think that's what we're really trying to get at, is decrease the joint moments at the hip and knee. So interventions, you can use a metronome app with your athlete. The other thing that you can do is a sagittal view with an iPad and have a look at their position of the leg relative to vertical at the point of initial contact. So this graduate student that I'm working on, he's trying to look at the relationship of the leg position. So this is to try to create a clinical tool that you guys can use every day to have a look at overstriding. And if the leg is more of an extended position at initial contact, it may be an indication of overstriding, versus here where you can see that the leg or the tibia is more vertical or more parallel to vertical. So this is a tool that you could use just with simply a side or lateral view with your iPad or iPhone. So we're going to figure out how that correlates with stride frequency, with forces and that type of thing. And most of our competitive athletes, we're talking about leading with the knee when you're running, not with the foot. And there you can see it in a little bit more detail. Now, so those are sort of the three areas right now, and there's other areas that we're exploring. But looking at decreased stride width or crossover, looking at overstriding or decreased stride frequency, and then looking at those typical medial collapse dynamics where you see the hip going into more adduction, internal rotation, and you see that contralateral pelvic drop. And as I mentioned in the literature, it doesn't appear that strengthening alone will totally ratify that problem, that you need to include some type of movement training. So the question that kind of arises for me, because what we like to do is we've studied runners, we have great sport medicine clinicians, and we want to take those same attributes and apply them to people that want to be active through walking as well. And so one of the questions that we're looking at right now is there an opportunity to intervene with individuals who want to remain active walking through the stride frequency adjustment? And can we do that while maximizing metabolic expenditure? So there's lots of people who want to just go for a walk to remain fit. My mom's one of them, so I hear about this all the time. So that's really the question, and we don't know a lot about how we can modify that. So this very interesting paper came out recently from Elizabeth Russell, who came into the UMass program after I was finished. And they wanted to look at obese individuals and what's the best way for them to walk or exercise to take advantage of the, maximize metabolic cost while decreasing the forces. So often people who have obesity will develop OA, and we want to make sure that we're decreasing the forces at the joint level while maximizing, fitness. And so they did this great study. And a number of people have looked at gait modification techniques for medial compartment OA, for instance, but no one's really yet looked at it from a fitness sort of point of view. So the question that we have is, adopting gait with a greater stride frequency and lesser stride length may increase metabolic cost while minimizing those deleterious forces that are often associated with OA, for instance. And the idea is really to try to decrease what is known as the knee adduction moment. That knee typically goes into more varum, more compression in the medial compartment, and different strategies have looked at how you can decrease that force. And there's a few different things that have emerged in a recent review by Simic et al. They've indicated that yes, you can decrease that knee abduction moment with contralateral cane use, with increases in stride width, with hip internal rotation, or lateral trunk lean. What's not clear is how step length, stride frequency, what the relationship is to decreasing that knee adduction moment, and this is the external moment. So one of the questions, and the Russell looked at, was if we modify step length, how does that affect forces at the knee? And the peak moments, or the peak knee adduction moment, was not decreased with increased stride frequency, decreased step length. But the impulse, or the area under the curve, was. And that impulse, we've looked at it a lot in other running injuries, is very important. It tells you more about the amount of force, or the amount of moment produced, and also the time over which it's produced. So one of the ideas that really came, I think, from the Russell work was you have to be able to control speed. So if you're out on the road, for instance, if you increase your speed, that's going to increase the forces at the joints. So we need to be able to find a way to keep speed constant, and treadmill is probably the easiest way to do that. So you can determine someone's preferred speed as they walk, and this is just a suggestion that we're playing with, and calculate or determine their stride frequency. So that would be their preferred speed, their preferred stride frequency that they adopt. Typically that is designed, or we select one that takes up the least energy expenditure when we're walking. So on the treadmill, we find their preferred, and then we, with the speed constant on the treadmill, increase their stride frequency by 15%. And I'm going to show you a lady in a moment that we've been working with, and this is all brand new. We haven't tested it by any means, but creating a constant speed scenario where people can adjust their step length through increased stride frequency. And so I'll leave you with this case study, which is a really fascinating lady that came in recently. She's a 60-year-old female walker and cyclist, and she's developing left side osteoarthritis in her hip. But as a child, she had her TA severed by a pop bottle, and it was never surgically repaired. So she's walked around for probably about 52 years with TA dysfunction. And she's doing fine, but when fatigued, has some episodes of trip and fall. And so her goal was to come in, and she really wants to remain active. This lady's energy was phenomenal. Wants to keep active and wants to do all that she can to, number one, stay active, but also prevent any future trip and fall episodes. So we did a walking analysis on her, and I actually also had her run. And here she is. And I spoke to her before I came on this trip to see how she was doing. So she had a mild drop foot on the left side. And in her data, when we looked at her dynamically, at initial contact, she was at about 10 degrees of plantar flexion at the ankle, both for walking and running, compared to the right side, which was about 10 degrees dorsiflexed. So we were trying to think of how to help her remain active and try to create a scenario where she could exercise and reduce the forces, particularly at the knee and the hip. So we had a look at her in detail, and we also saw that in her left ankle there was typically more adduction or in-toeing. And so when her foot was hitting the ground, she was plantar flexed and in-toed or adducted. Her pelvis, there was a lot of asymmetry between left and right sides, and her stride frequency was quite decreased on her left side. So there was actually an asymmetry in her stride frequency, which is quite interesting. So we collaborated with podiatry, and She was dispensed a dynamic assist Ritchie brace with the tamarack hinges, which she called me and told me she walked down the hall and she had never felt better. The strain, she said, left my left side. So she had been battling this for years, and with the use of this brace, she was just free. She felt like she was free. She had to adjust a little bit, she said, but very comfortable and very happy. We collaborated with physiotherapy, and she worked a lot on her core stability and trying to address some of those asymmetries that we saw in the pelvis that may have been affecting her hips. And then we did a little work on increasing her stride frequency. And her feedback to me was that she felt that she was getting a much better workout with a lot less force on her body. And that's what you would hopefully be aiming for. So she was so excited. She had this new fancy shiny brace that our friend is responsible for. But also she felt like, you know what, I can go for a walk now and I don't feel that strain, the force on my body that I experienced in the past. And I feel like I'm getting a better workout. So just an idea and something that we're going to explore a little bit for the walker. So thank you very much. And Martin and I too want to thank you for last night. That was lovely. I should acknowledge that Paris Orthotics was responsible for getting me here in the airplane, and Firefly. I want to thank Firefly for looking after me while I'm here. So thank you, Martin. You've done an excellent job.
Okay, you're welcome.